Welcome back to the lecture on the pair formation models in the context of sexually transmitted diseases. In the previous models, we took a look into the formulation of such models by considering pair formation process and coupling it with the disease transmission dynamics. Now, in this current video, we will take a look on how these models were used in the past for consultation of public health decision making. Now we will take a look at a specific disease. We will take a look at chlamydia. It is fairly common in most developed countries. As a matter of fact, in the Netherlands, it is a most common disease in the population of women and heterosexual men. Such that cohort that is most at risk for infection is young women aged 20 to 25 years. Now, infection with this disease may or may not be symptomatic. If left untreated, it may cause complications such as pelvic inflammation, prostate inflammation in men, and infertility in women. This disease is overall thought to follow an SIS framework where the immunity that possibly may be obtained from having this infection is of very short duration, although there is more work that's being led in this direction. Now, combination of all of these factors makes this a challenging disease to eradicate from the population. And so the question right now is, what sort of interventions are available and how efficient and cost-effective these interventions are in protecting the population and reducing the prevalence of the disease. In this lecture, we will consider three different interventions that could be deployed and were deployed in the past in order to curb the spread of chlamydia in the population. These interventions are a random screening of the population, partner notification, and the repeated testing of previously infected individuals. Now, screening involves randomly picking individuals, inviting them for screening, testing them, and if they're infected, treating them. It is somewhat expensive. Individuals that are targeted not necessarily will come in, and these that will come in might not necessarily be super spreaders or be altogether infected. Now, the second intervention that we consider is a partner notification program. So say we're looking at this initial individual that we found out to be infected through a screening program, and we might also deploy a partner notification. So we will ask them to think back, for example, 6 months and contact all of their sexual partners from the 6 months back and ask them to come in for testing. As the result of looking back and finding the partners, some of the individuals might come forward, get tested, and as the result, if they're infected, obtain the treatment. Finally, using the same example, the initial infected individual, the repeated testing involves inviting for testing individuals who have already been tested positive, and asking them sometime later to come in and get tested again to provide for the possibility that they might be reinfected by their current partner that never showed up to get tested altogether. Here are some examples of existing guidelines for the interventions targeted for the sexually transmitted diseases. Now, some countries have screening for a specific strata of the population. You can see here these are, for many countries, are women or young individuals aged 24, 25 or younger. Most countries would have a partner notification program where the infected case can be asked to either list their partners within a certain time period, be it days, months, maybe even year, or they're asked to think back and give a list of their ex most recent partners. For example, please give us the contacts of your 5 most recent sexual partners. Now, both of the screening interventions and partner notification can then be followed by repeated testing, where either the index case or their infected partners may be asked again to come in for repeated testing sometime later. Now, if one does not have a concern for the fiscal side of things, one could argue that, well, why not deploy all 3 of them, and this will be the best option. But more often than not, we need to assess which method or combination of methods will give the most bang for buck. And in order to assess the effect of various combinations, mathematical models, and in the specific example that we will be looking at, agent-based models will be very helpful. So below you see the outputs of an agent-based model that couples a pair formation process with the disease transmission dynamics. Now, in this model, it allows only for monogamous serial relationships to take place, so individuals can be at most 1 relationship at a given time. Overall, in order to illustrate this specific example, we depict individuals as nodes that can either be infected or not, which is reflected in the color of the node. So a filled-in circle would be an infected individual, empty circle would be a susceptible individual. In addition, of course, people can either be single or in a relationship. And if any 2 individuals are in the relationship and at a specific point in time, they would be connected by an edge, if we're looking at the visual representation of the dynamics. Now, on the left-hand side, you see the state of a population at some specific point in time. So your simulation runs, you press pause, and you look at the visual representation of the population at that specific times. So here we see that some nodes are in pairs, so some nodes are connected by an edge, while others are disconnected from anybody. And most importantly, you can see that each individual can be connected to at most 1 partner. Now, this is an interesting insight, but very expected and only as informative until a certain extent. For example, we can take a look at what is the amount of people who are currently in the relationship in the population. But as far as the STIs go and interventions that target them, we of course care about the chains of the partnerships, past and present. And so the figure on the right hand side represents the collection of all partnerships that existed through the last year from the current pause of the population, irregardless of the duration of these partnerships. And then from this figure, you can see that each individual in the population has been or is now in at least 1 relationship throughout the year. And a large portion of the individuals had actually more than 1 relationship. So this is a fertile ground for the spread of sexually transmitted infections. And so, for example, if we have this individual X marked with the red circle, who is infected, who for some reason has gotten tested, either because they were experiencing the symptoms or they were targeted as a part of the random screening program, they will have to notify individuals that they are dated within the last year, if, for example, in this population a partner notification program is deployed. Now, this visual representation immediately lets us know which individuals they will have to target, as they list all individuals that this person dated within last year. Now, let's consider the population where only partner notification intervention is in place. As mentioned, a partner notification program can ask you to go back either X partners back, or it can ask you to think back to your partners of the last Y number of months. Of course, ideally, why not ask individuals to think back to all of their partners or to think back to all of their sexual history. But of course, this will result in a price of contacting all of these people, even if the initial individual can remember them, and then testing them. And the question is, would it even be an effective solution to the problem? Do we really need to go this much back? And in order to assess how far is far enough, we will look at the probability of partners being infected depending on how recent their relationship was with the infected initial case. So what we're looking here at is probability of the partners being infected depending either on the recency of their relationship with the initial case, with a non-infected case, or probability of partner being infected as a function of the time that since the termination of their relationship with the given infected case. Overall, as we look at both of these graphs, we see that no matter how you slice it, the more time has passed since the completion of a relationship, the lower is the probability that this partner will be infected once they will be contacted as a part of the partner notification program. However, note that even though the probability of being infected decreases as the recency of the relationship with the initial case increases, this probability never goes below the baseline prevalence of the chlamydia in the population. So from the point of view of the benefits to individuals, of course, it pays to actually to try and think back as many partnerships or as much time as you can possibly can in order to make sure that you've contacted all these who could potentially be infected. However, once we switch our priorities from the individuals towards the effective use of intervention, we see that the best gains that we get from these partner notification programs, we only obtain them when we, for example, contact the last 3 most recent partners, where the gains substantially decrease if the most recent partner happens to be 4th or 5th. Similarly, if you look at the recency of a relationship in terms of time, it really pays to, for example, look at the partners from the most recent one up to 16 to 18 months old relationships, where you would get a fairly high chance of targeting somebody who is indeed infected, but there is a much lower gains in contacting something that was that much more in the past. But once again, these remaining partners still run a higher probability of being infected than an average person in the population. Now, we've looked at only one intervention that's been deployed in the population. Perhaps its outputs will be better if it's combined with some other interventions such as random screening and perhaps even repeated testing. So let's look at the combination of partner notification program with some other interventions. So what we consider first is a so-called moderate screening intervention in a general population, where we're saying that we're screening 10% of the population per year for 5 years straight. This screening will be combined with a partner notification probability, where people who happen to be found to be infected as a result of screening uptake will notify their partner, who will consider to come in for testing with probability 50%. We are assuming that whoever will come in for testing will be found infected will be treated with 100% efficacy. And we will test the effect of these interventions in a population with the baseline prevalence of 3%. And we will look at the effect of this intervention as expressed in this following output of the model, output in the chlamydia prevalence. So once again, we will look at two types of partner notification programs. One that will ask individuals to think back about their most recent partners, or the other one that will ask individuals to think back to all of their partners within a specific time period. And let's see what happens when all of these are in place. Overall, we see as the number of notified partners increases, the chlamydia prevalence for this intervention decreases for the combination of the interventions. Now, if partner notification is performed for at least the most recent partner, the prevalence is reduced to below 60% of the baseline prevalence. But increasing the partner notification periods results in a slight but steady decrease in prevalence as well. However, once the number of notified partners exceeds a certain threshold, or once the time period of notification exceeds a certain threshold, no significant additional benefits could be gained as far as the population level prevalence reduction. So as far as the partner notification period, apparently, if you notify your most recent partner, that should already provide substantial gains. At most, you are asked to think back. You could be asked to think back to at least one more relationship or several months if we're thinking about the time periods instead of the notified partners. So this was an insight of how the partner notification program can perform when combined with a random screening program. Let's now consider what happens when a partner notification program is supplemented with the repeated testing intervention. And note that this intervention operates on the premise that if you were infected once, it is possible that you will get infected again. Let's consider an illustration. Say you start with some number of infected individuals. Some of them got picked for screening, tested, and treated. Now, within a certain period of time, it's possible that some of them got infected again, but since we're now deploying a repeated testing program, they're highly likely to be detected by the system again. Of course, the question for this repeated testing program is at which interval should we contact these individuals for a new round of testing. Ideally, we would want to be testing done to be frequent enough so that most cases will be detected without them going around and spreading the disease, but not that often that most of the individuals that we will ask to come in for testing will still be susceptible. And moreover, how is this ideal optimal interval for the repeated testing depends on other interventions such as partner notification that's being deployed simultaneously in the population. So we can once again tackle this question with the help of a mathematical, in this case, agent-based model. And here we see a brief summary of the conclusions that such an analysis with a mathematical model gave us. So in this specific case, we have a population where random screening and partner notification program is in place. Say we're mostly targeting women, and women who got screened and tested may choose to inform their current partner who will come in for testing with a variable level of probability. If they do come in and they happen to be infected, they automatically get treated and recover. And now for these different types of partner notification rates, we will look at the curves that capture proportion of women with repeated infection and their evolution in time. And of course, the time recurrence of the peaks of those curves will be good candidates for the optimal time for the repeated testing interval. We're seeing that the probability of reinfection provided different rates of notification overall decreases as the partner notification success rate increases. We see that in the case where there is a zero chance of a partner coming in the peak of the curve occurs at a mark of 3.4 months, and as the success rate of partner notification program increases, this peak both becomes lower and reduces to the left to the mark of 3.2 months. So the moral of the story here is the higher the partner notification rate success with only the most current partner being interviewed, the sooner the repeated testing interval, the shorter the repeated testing interval should be in order to catch maximum possibility of the reinfections. Finally, we consider the effects of combination of all three interventions on the chlamydia dynamics in the population. We are looking at the screening uptake of 10% per year in a population where it's deployed for 5 years straight. We are assuming that there is a partner notification program in place where only the most recent partner is being notified, such that the probability that this partner will come in for testing is 50%. And we will deploy repeated testing after 3 months from the initial positive test, with a probability that an individual will agree to come in for testing given by 50%. We assume that this intervention package is deployed in a population where chlamydia is endemic and its baseline prevalence is 3%. And we are once again, I will be looking as an outcome on the reduction of chlamydia prevalence in the population. So we will be taking a look which combination of these three possible interventions gives us the most reduction. And so let's see the effect. Now we have the black line called testing, which is essentially the random screening program. We see that screening alone, as deployed for 5 years, indeed reduces the prevalence. Combining the screening with any one of the other two interventions results in the further decrease of the prevalence, although these additional decreases in prevalences may be dependent on the actual intervention that's being combined with the screening. For example, we see that if the screening is combined with a 50% partner notification, we see quite a significant decrease. While on the other hand, if we combine the screening program with the repeated testing uptake, the improvements on decrease of chlamydia prevalence are much more modest. And of course, once you combine all three interventions, you get the most decrease. But observe that if we will compare the green line where screening is combined with partner notification, if we add repeated testing uptake, the gains that we gain are rather modest. And so it seems that the most optimal combination that will give us the most decrease would be to deploy random screening and combine it with a partner notification uptake, provided that we can guarantee at least a 50% success rate of this partner notification, i.e. the partner will agree to come in and get tested. So what can we say after taking a look at these different combinations of interventions? What sort of recommendations can we give? So from all the graphs that we've seen today, we see that as far as the partner notification programs goes, priority should be given to the most recent partner. They are the most important person to contact should one be infected. And it seems that going beyond the most recent partner is almost not cost efficient, although it really depends on the perspective from which you're looking, whether you're looking from the population level impact or from individual level impact. From the point of individual gains, of course, the more partners you can notify, the better. Now, as far as the repeated testing intervention goes, optimal retesting interval seems to be between 3 and 5 months after treatment. this interval can be shorter if a partner notification program is in place. Both interventions combined would give better results than each single one of them as deployed by itself. And this concludes our excursion into the insights that the pair formation models can give to the public health authorities as far as the design of the interventions aimed at mitigation of the spread of sexually transmitted infections. Overall, as far as the pair formation model go, they have limitations and they have strengths. As if you choose to deploy a pair formation model in the form of the deterministic model, the more structure you want to add leads to much more equations, and so you might end up actually using an agent-based model instead of the deterministic model. Specifically, overlap in partnerships and concurrent partnerships are difficult to incorporate in the deterministic model, and you most likely inevitably will end up with agent-based model. However, on the positive side, there are advantages to using a pair formation model. They're flexible, they can incorporate quite a number of realistic features as far as the partnership formations go, and if you can get away with formulating equations rather than going for agent-based model, you will end up with relatively simple systems that might lend themselves for the theoretical analysis, which is always a good thing. Some take-home messages from today. Irregardless of whether your model that you use for modeling of sexually transmitted diseases, how it's formulated, you will need to parameterize it, and it's challenging. There is a number of reasons for that, starting from the sensitive nature of the questions and ending with various biases that might be present even when individuals would like to answer the question in your service truthfully. However, incorporating the partnerships and their formation and dissolution process is crucial when modeling sexually transmitted infections, since these relationships are the drivers of the dynamics of sexually transmitted infections. And these models are a very good tool for evaluating the impact of intervention or intervention packages in order to control sexually transmitted diseases. This has been a very brief intro into the subject. If you would like to read much more, there is a fairly large body of literature that's available, some of which I list here. For a quick primer on the subject of pair formation models and their deployment in the modeling of sexually transmitted diseases, consider this very first bolded paper that should be sufficient for both from the point of view of usefulness of such models and mathematical formulations that went into their design. This concludes this lecture on the pair formation models. Thank you very much for your attention.